Hello, welcome to our channel. We have a humble request to make. Please subscribe to our channel. And if you like it, please share it with medical students, postgraduate students, practicing providers, and also those who are interested in medical topics. We provide seminars live every Sunday. All those seminars will be uploaded in our YouTube channel and WhatsApp channel. With that introduction, let's move on to the topic, which is Pediatric Dermatologic Emergencies Part 2. Even though it says pediatrics, we do speak about adults in appropriate circumstances. And we are going to talk about necrotizing fasciitis, meningococcemia, hemangioma, and IgA vasculitis, and also called as Henoch-Schönlein Purpura. The first, necrotizing fasciitis. Necrotizing soft tissue infections are rapidly progressing skin and soft tissue infections that lead to extensive tissue necrosis affecting dermis and epidermis and often involving the deeper layers of fascia and muscles, leading to systemic illness and increased morbidity and mortality. As the name says, it involves not only fascia, it also involves the deeper layers and also the superficial layers. As the picture depicts, it involves skin, fascia, and muscular tissue, and it gives a hue of violaceous color around the lesion. The annual incidence in the United States is 8.7 to 10.3 cases per 100,000 individuals. Countries with warmer climates have higher number of patients per 100,000 individuals. In Thailand, it was reported as 32.64. More infections happen during summer. The risk factors for necrotizing fasciitis are chronic kidney disease, diabetes mellitus, liver cirrhosis, alcoholism, valvular heart disease, and stroke. Necrotizing fasciitis often seen in chronic kidney disease and liver cirrhosis, hence it's highlighted. This slide shows the factors conferring predisposition to specific necrotizing soft tissue infections. The predisposing factor could be trauma. The trauma could be either major penetrating trauma, minor penetrating trauma, or minor non-penetrating trauma, just a mucosal breach or skin breach. Or it could happen in immunocompromised host and women, pregnancy, childbirth, abortion, and occult factors. In major penetrating trauma, the major organisms are Clostridium perfringens, Histolyticum, and Nevi. That causes gas gangrene. In minor penetrating trauma, it could be from freshwater laceration caused by Aeromonas or saltwater laceration, Vibrio vulnificus. The non-penetrating trauma, the major cause is Streptococcus pyogenes. When there is a mucosal breach like rectal, vaginal, urethral tear, or GI, genitourinary, or gynecologic surgery, oftentimes caused by mixed aerobic and anaerobic organisms. Following varicella lesions, often caused by strep pyogenes, insect bites, strep pyogenes, injection of drugs, often associated with, again, Clostridium organisms like perfringens, Histolyticum, Nevi, and Sordelli. Immunocompromised host can cause in diabetic patients both mixed aerobic and anaerobic organisms. In cirrhosis with ingestion of raw oysters associated with Vibrio vulnificus, neutropenic patients often have infection with Clostridium septicum. Women the most common being strep pyogenes, Clostridium perfringens, and Clostridium sordelli. And occult like colonic lesions, including carcinoma, you tend to get infection from Clostridium septicum. Necrotizing soft tissue infections are associated with high mortality rates. It used to be real high, 28%, before 2000. Because of the early detection of necrotizing soft tissue infection, decreased the mortality to almost 15%. It's most commonly caused by strep A, streptococcus. There are 4 types, as been described. Type 1 is often associated with polymicrobials like E. coli enterococcus species. Type 2 NSTI is often caused by monomicrobials, often caused by gram-positive organisms like group A streptococcus or Staph aureus. The type 2 NSTI occurs without an obvious of injury, so it is unlikely to be caused in healthcare setting. Type 3 NSTI often caused clostridial or caused by gram-negative microbials like Vibrio, Aeromonas, Klebsiella, E. coli. Type 4 is caused by fungal infection. It can happen following traumatic wound, burn, immunocompromised host, and after natural disasters like tsunami or typhoon, etc. The pathogenesis, when there is a defined portal of entry, the skin or mucosal breach that introduce spores or organisms into the body. They proliferate and liberate exotoxins. It causes initially vasodilation and followed by platelet and leukocyte aggregation, and that results in erythema and swelling. If it was unattended, then bullae and ecchymosis develop as a result of the clogging of capillaries. If it is still unattended, it will further deepen, the infections go further deep into the subcutaneous and muscular layer, then outward manifestation like large bullae will manifest. When there is no defined portal of entry following sprain or deep tissue injury, what happens is there is increased vascularity at the place of trauma. In a susceptible host with a transient bacteremia, the bacteria come and lodges in the deep tissue and releases exotoxin. That causes venous occlusion, resulting in inflammation in the deeper tissue. There will not be any subcutaneous manifestation. Then if it was unattended, infection spread upward, eventually resulting in ecchymosis and bullae. So the clinical presentations, classic triad of necrotizing fasciitis are pain, swelling, and erythema. The question is how to differentiate necrotizing versus non-necrotizing. Number one is the pain will be out of proportion to what you see, the outward manifestation. But one has to remember, in patients with diabetic neuropathy and those who are taking painkillers, it may not be very apparent. Within 1 to 2 days of infection, the bullae and the vesicles may begin to form. Then serosanguinous leakage happens. We call it as intermediate stage of necrotizing fasciitis. In the late stage, one can see skin necrosis and crepitus. There are pitfalls in the diagnosis of necrotizing soft tissue infection. One has to have a high index of suspicion. Number one, they may not have any fever. Number two, they may not have cutaneous manifestations, especially in a spontaneous or cryptogenic necrotizing infections. And third, the pain often attributable to the injury or the procedure. Severe pain is a key finding in patients with the necrotizing infections. But if they are taking the medications, that pain can be less than what we expect. And also, the pain may be attributable to the surgery or parturition. And when they have a perennial pain, that can be attributed to hemorrhoids, epididymitis, or vaginal or rectal trauma. If the pain is out of proportion to the suspected cause, requires opiates and ketorolac for management rather than looking for necrotizing infection. And non-specific imaging test. In the absence of gas in the deep tissue, in the absence of having MRI that could differentiate from necrotizing to non-necrotizing tissues, easily miss. And attributing systemic manifestation to other causes like nausea, vomiting, diarrhea may be early manifestation of GAS, group A streptococcus infection, though they often wrongly attributed to food poisoning or viral infection. This flow diagram shows how to differentiate necrotizing versus non-necrotizing. When the patient has swelling, erythema, pain, when there is an absence of systemic signs, it could be because of cellulitis, erysipelas, and cutaneous abscess. Even those patients, you can continue to observe and watch other symptoms, whether they develop or not. But when there is an obvious things like tachycardia, more than 120 beats per minute for adults, for children, age-appropriate tachycardia, hypotension, elevated CK level, CRP more than 15, or LRI-NAC score more than 6, suggestive of necrotizing bacterial infection. This is how it looks clinically. Erythema, swelling, and there is no breach in the skin. This is a post-operative picture. They debrided the necrotic area and left it open. Sometimes you will have full-blown gangrene necessitating amputation. There is no gold standard lab test for diagnosis of necrotizing fasciitis. Lab risk indicator for necrotizing fasciitis using white cell count, hemoglobin, sodium, glucose, and creatinine and CRP is widely used to differentiate necrotizing versus non-necrotizing. The score of 6 or higher strongly associated with necrotizing fasciitis with a positive predictive value of 96%. MRI is the preferred modality for NF. The T2 weight sequences can distinguish necrotizing tissues versus non-necrotizing tissues. CT can be used as an initial imaging study if it is available early and if the MRI is not available at that point. But MRI is the go-to. During the initial phases of necrotizing fasciitis, especially in immunocompromised patients, physical signs may not be evident and only tissue swelling may be apparent. This table shows LRI-NAC score. They use C-reactive protein, white cell count, hemoglobin, sodium, creatinine, glucose. There are separate scores given for each element. If the score is 6 or above, it is very suggestive of necrotizing fasciitis. This diagram shows when it is obvious necrotizing fasciitis, the patient needs to go to the emergent operative debridement. But in equivocal cases, the LRI-NAC help to differentiate necrotizing, non-necrotizing. When the score is above 6, there is a high chance the patient has necrotizing fasciitis. Another scoring system just missed few months ago called necrosis scoring system. They used three variables: systemic blood pressure, white cell count, and violaceous skin. Systemic blood pressure is less than 120, white cell count more than 15, and violaceous skin. It's sensitive enough to detect necrotizing fasciitis. The treatment for necrotizing fasciitis is immediate and extensive surgical removal of necrotic tissues. All patients should have post-operative reassessment, which may include second-look surgery. Sometimes they may need amputation. The IV antibiotics needs to be given right away. Most often, it involves vancomycin plus piptazo or carbapenem. When the group A streptococcal infection was suspected, clindamycin should be added. Empiric antifungal therapy is not indicated except patients who are immunocompromised and also after natural disasters. When the strep pyogenes or Clostridium was suspected, one should treat them with and clindamycin. Clindamycin as a monotherapy is not recommended. When you suspect Clostridium tetani, tetanus immunoglobulin should be given along with antibiotic. Continue the antibiotic for 48 to 72 hours after the last surgical debridement in the setting of marked clinical improvement. IV immunoglobulin had been used before, but it has a doubtful benefit. So does hyperbaric oxygen therapy. When there is a clostridial infection, one can try, but the benefit is again doubtful. And some patients may end up needing soft tissue reconstruction after the recovery. This slide shows different antibiotic choices based on the etiologic agent. We'll go on. Staphylococcus aureus. The initial antibiotic choice is vancomycin, 20 to 30 milligram per kilogram loading dose, followed by 15 to 20 milligram per kilogram every 8 to 12 hours, or linezolid, or daptomycin, or dalbavancin. It used to be given, the recommended duration is 7 to 14 days and 48 to 78 hours from achieving healthy tissues, and the patient has clinically improved. Strep pyogenes, penicillin plus clindamycin. Polymicrobial infection, most often the causative organism in type 1 necrotizing fasciitis. Those patients, piptazo, meropenem, or imipenem. In those patients who had, or in those areas where the carbapenem resistance is high, more than 15%, ceftriaxone, tazobactam combo plus vancomycin plus clindamycin should be used. For Clostridium tetani, penicillin plus clindamycin. And Vibrio species, third generation cephalosporin plus one of these three, doxycycline, minocycline, or ciprofloxacin. Neromonas species, ciprofloxacin, doxy, or mino, or cefepime. One of those can be used to treat them. The second one is meningococcemia. Neisseria meningitidis is a leading cause of sepsis and meningitis in young children and adolescents. It's caused by gram-negative diplococci. There are multiple serotypes that are present. Serogroup A found in Africa, especially in that meningitis belt that starts from Senegal all the way up to Ethiopia. Subgroup B and C been seen in Europe. Subgroups B, C, and Y are seen in North America. The incidence rates of meningococcal disease have decreased in the since 1995, most likely because of the meningococcal vaccination. If you look at age-related incidents, during the first 10 years, the incidents are higher. Then there is increased incidence during adolescence and early adulthood. Then incidence goes up after 65 years of age. Based on the serogroup, the serogroup B being the predominant reason for the infection in the first year of life, and also in subsequent years, it plays a significant role. Even though anybody can get infected with the meningococcal disease, there are certain group of patients, they are more vulnerable for invasive meningococcal disease. Those who have persistent complement component deficiencies, those who have anatomic or functional asplenia, HIV infection, travel to the meningococcal belt. And also during Hajj, they are increased risk to develop invasive meningococcal disease, and risk during a community outbreak, and those who work in the lab dealing with IgA meningitis. These are all the high-risk persons to get invasive meningococcal disease. Invasive meningococcal disease may initially present with fever, headache, and myalgia. The progression is often rapid. Hospital admission usually occurs within 24 hours. 50% of the patients have meningitis, and other half can have sepsis or both sepsis and meningitis together. Meningococcal meningitis will have typical signs of meningitis like irritability, neck stiffness, headache, vomiting, and altered level of consciousness. The early signs of meningococcal sepsis are fever, weakness, pallor, mottling, or cold hands and feet. The rash can begin as a macule or papule that become petechial. It's often non-blanching within hours. DIC, purpura fulminans leading to gangrene, multi-organ failure happens quickly. So the pathognomonic sign of meningococcemia is a rapidity of the progression. It can cause adrenal hemorrhage, leads to adrenal insufficiency, the so-called Waterhouse fluoridation syndrome. The case fatality rate for meningococcemia is very high, about 15%. The risk factors for mortality when they have hypotension, coma, leukocytopenia, thrombocytopenia, or absence of meningitis, these patients have a higher mortality than others. In addition, up to 20% of the survivors have long-term sequelae like loss of limb, hearing loss, and neurological disability. These patients often have post-infectious inflammatory syndrome characterized by fever, arthritis, vasculitis. It occurs in less than 10% of the patients. This is because of deposition of antigen-antibody complex begins few days after treatment and resolves spontaneously within few weeks. This picture depicts an infant with meningococcal sepsis. As you can see, that is vast area of necrotic tissues. There's another few pictures showing ecchymotic lesions in different parts of the body. The diagnosis is by isogram negative diplococci. Positive cultures from blood, CSF, and the skin lesion will help to make the diagnosis. Blood cultures positive in 40 to 75% of the time, CSF cultures positive in 90% of the time. The WHO defines meningococcemia as a confirmed case, suspect, and probable case. In order to have a confirmed meningococcal septicemia or meningococcemia, when you isolate bacteria from blood, CSF, synovial fluid, pleural fluid, pericardial fluid, or from skin lesions, it could be Just PCR or say positive for Neisseria meningitis in all those areas can confirm the diagnosis of meningococcemia. In probable case, the clinical signs are like meningococcemia, but only the antigen test is positive. The culture and the PCR is negative. It can happen if the patient received antibiotics earlier. In suspect case, the clinical scenario is similar to meningococcemia, but we could not able to have gram-negative diplococci in any of the sterile field or from skin lesions, or having a purpura fulminans without positive culture. Invasive meningococcal disease is a medical emergency. So early antibiotic therapy and the early management shock improves the outcomes. Ceftriaxone should be administered intramuscularly once the diagnosis is suspected. Drug of choice is third generation cephalosporin such as ceftriaxone. When you suspect meningitis, ceftriaxone should be combined with vancomycin. Meningococcus in CSF are killed within 4 hours. So if you do a tap after 4 hours, you may not be able to get meningococcus in the culture. Ceftriaxone clears nasopharyngeal carriage after 1 dose. The duration is 5 to 7 days for meningococcemia and meningococcal meningitis. For hospitalized patients, Doppler precautions are recommended until 24 hours after initiation of effective antibiotic therapy. This slide shows the antibiotic chemoprophylaxis for those who are exposed to meningococcal infection. The household contacts and those who are exposed to the patient the previous 7 days should be given antibiotics as shown in this particular slide. The drug used are rifampin, ceftriaxone, ciprofloxacin, and azithromycin. The rifampin is not recommended for pregnant women. Ceftriaxone can be given safely to the pregnant women. In children less than 15 years, 125 milligram single intramuscular injection. More than 15 years, 250 milligram single dose. Ciprofloxacin 20 milligram per kilo, maximum 500 milligram. It's not recommended routinely for persons less than 18 years. Azithromycin 10 milligram per kg, maximum 500 milligram single water dose. Meningococcal vaccinations available with the different serotypes. This Novartis vaccines available for patients 2 months and above. And there are specific recommendations for different groups, like the patient with complement deficiencies and patients with functional asplenia, and those who are traveling to the endemic or epidemic areas. And this again, 2 months to 23 months and 24 months to up to an adult age. And the vaccinations are very similar, but the dosing and the frequency differ from these 2 age groups. The meningococcal B vaccines, particularly for those patients in adolescent and early adulthood years, that is the most common infections in that age group. Please visit CDC website to get accurate information about vaccination. The third topic is Henoch-Schönlein Purpura. IgA vasculitis, it's often called as Henoch-Schönlein Purpura. It used to be. It affects 10 to 20 children per 100,000 population. Most common vasculitis of childhood. 75% of those diagnosed as having HSP are younger than 10 years. Peak incidence happens between 4 to 6 years. White and Asian children are most commonly affected. There is male predominance. It is an IgA mediated systemic small vessel vasculitis with predilection for skin, kidneys, GI tract, and joints. There is a genetic predisposition to HSP. 50 and 75% of the patients with HSP have history of preceding URI. Step pyogenes being the most common organism. But there are a humpty number of viruses and bacteria can cause HSP or associated with HSP. There are drugs that have been incriminated in association of HSP and other precipitating factors like insect bites, coarse serum, alpha-1 antitrypsin deficiency has been associated with HSP. So does lots of vaccinations as enumerated here. Clinical manifestation. The purpuric or petechial rash in pressure or gravity dependent distribution is present in almost all patients with HSP. The characteristic distribution is in older children, the ventral aspect of the feet, ankles, and lower legs. In younger children, you will see the rash in buttocks, back, and upper thighs. Face, trunk, palms, soles, and mucous membranes are usually spared, except in infants in whom facial involvement is not uncommon. It is symmetrically distributed in most of the patients. The rash is palpable and does not blanch. It can coalesce to form large plaques that resemble accumulations. Rash is not itchy or painful. Eruption in children appear in crops over an average of 3 weeks. Often it's polymorphic in nature in children. That means you will see different sizes and shapes. It's monomorphic in adults. There is a uniformity of the rash in adults. The color of purpura progresses from red to purple, then to rust color or brown as the rash fades. The color change occurs over approximately 10 days. Subcutaneous edema is reported in 35 to 70% of the patients. Edema is non-pitting, usually noted on the dorsal surface of the hands and feet. It can occur in scalp, ears, periorbital area, and abdominal wall. As you can see here, it is symmetric distribution. The color is very typical of Henoch-Schönlein Purpura. Sometimes these purpuric lesions coalesce to form ecchymotic appearance. And you can see the edema in the dorsum of the feet. And this rash is palpable, but it's not blanchable. It also can present as arthralgia and arthritis in 65 to 85% of the patients. Younger children are more frequently affected. Large joints in lower extremities, especially knees and ankles, are most commonly affected. Usually is symmetrical and non-migratory. Only few, that means less than 4, are affected. Arthralgia or arthritis is usually transient and does not lead to permanent disability. Myositis is rare but has been reported. GA involvement occurs in 50 to 75% of the patients. 10 to 20% of the patients, GA manifestations precede skin manifestation, meaning the patient can present with acute abdominal pain. A day later, the rash appears on the patients. Abdominal pain is more common and more commonly colicky in nature, but it can be dull aching. Pain usually diffuse, but may be localized to epigastric and periumbilical. Other manifestations such as nausea, vomiting, hematemesis, and melena can happen. Intussusception is seen in 3.5% of the patients. Oftentimes, it is ileocolic in nature. The protein-losing enteropathy is seen in 3% of the patients. Renal manifestation seen in 40 to 50% of the patients. 97% of the patients will have renal manifestation within 3 months of the disease onset. Glomerulonephritis, the most common. Hematuria is most common manifestation. Other findings such as proteinuria, nephrotic syndrome, and acute nephritis with hypertension can be seen as well. Persistent hematuria and proteinuria predict end-stage kidney disease. The risk factors for renal involvement are as follows. When the patient presents with severe abdominal pain, GA hemorrhage, age more than 5 years at the onset, persistent purpura more than a month, scrotal involvement, obesity, elevated serum IgA, elevated CRP, and decreased C3 levels often tend to develop renal disease. RKT is present in 10 to 20% of the boys. The clinical manifestations are pain, tenderness, and swelling of the testicle and the scrotum that can mimic testicular torsion. So scrotal involvement is seen in 20% of the boys, and it can have other manifestations such as penile edema, priapism, epididymitis, hematoma of the spermatic cord, testicular infarction, and thrombosis of the spermatic veins, scrotal hematoma, or labile edema. 30% of the patients will have neurological symptoms. It can manifest as headache, dizziness, or behavioral changes such as irritability, hyperactivity, apathy, and mood lability. In 2 to 8% of the patients can have seizures, visual abnormalities, verbal disability, confusion, ataxia, and focal neurological deficit. Rarely, they can present as peripheral neuropathy, facial palsy, myelopathy, intracranial hemorrhage, subarachnoid hemorrhage, subdural hematoma, cerebral venous thrombosis, Guillain-Barré syndrome, encephalopathy, and posterior reversible encephalopathy syndrome. It can present as alveolar hemorrhage, interstitial pneumonia, interstitial fibrosis, and poor perfusion. It can cause myocarditis, myocardial necrosis, or infarction, uveitis, and as the slide shows, there are lots of conditions in children or adults can present like purpura, arthralgia or arthritis, and acute abdominal pain. There are no lab studies definitely confirm the diagnosis of HSP. Almost 50 to 70% of the patients will have elevated serum IgA. Renal involvement is predicted when when urine analysis shows RBC, white cell, RBC, WBC, cellular cast, and or proteinuria, elevated serum creatinine and BUN. CBC and coax studies often done to rule out other causes. CRP, sed rate, D-dimer, and FTP often elevated in patients with HSP, but they always have normal ANI, double-stranded cDNA, C3, C4, and ANCA. Those are all invariably normal in patients with HSP. The renal biopsy is indicated when there is a severe proteinuria lasting at least 4 weeks, or persistent moderate proteinuria with impaired glomerular filtration rate. How to make the diagnosis of HSP? There are 3 organizations, mostly based out of Europe. They came up with a guideline how to do the diagnosis. You got to have a palpable purpura along with one of these 4. Acute onset of diffuse abdominal pain, arthritis or arthralgia, renal involvement, or biopsy showing predominant IgA deposition. Sensitivity of this model is 93% and specificity is 89%. Most cases of HSP have an excellent outcome. Renal involvement is an important prognostic factor. The average duration of the illness is except for those with persistent proteinuria or hematuria. 30% of the patients will have recurrence, especially those with renal involvement or received steroid for more than 10 days. Recurrences occur mostly within a year. Sometimes it may happen several years later. The long-term consequences are rare, except those who had renal involvement with persistent hypertension and end-stage kidney disease. The treatment is often supportive. Most cases are self-limiting. So quiet activities, optimal nutrition, and adequate hydration, along with pain relievers with acetaminophen, paracetamol, and non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs should be avoided in patients with GA hemorrhage and renal insufficiency. Urine analysis and BP, blood pressure, should be monitored weekly for the first few months, thereafter monthly for the first year, and every 3 to 6 months thereafter. Children with renal involvement should be on low salt diet. Current evidence does not support universal treatment of HSP patients with corticosteroids. So when to use steroids? The indication for corticosteroids are as follows: abdominal pain, intrapulmonary hemorrhage, persistent nephrotic syndrome, severe scrotal edema, architis, and cerebral vasculitis. The use of steroids should be balanced against its side effects. When you use immunosuppressive therapy with steroid, it induces remission in patients with HSP nephritis quickly. Renal biopsy is indicated when there is an acute renal impairment or nephrotic syndrome at presentation, or when they have persistent proteinuria, and in those patients with rapidly deteriorating renal function. The hospitalization is necessary for the following conditions: when there is a severe GA bleeding, severe abdominal pain, renal failure, perforation or mesenteric perforation. Of course, they need surgical intervention right away. Finally, we will talk about infantile hemangioma. It is the most common pediatric vascular tumor. It affects approximately 4% of infants. The reported incidence varies anywhere between 2 to 10%. There is an increased incidence of infantile hemangioma in the past 4 decades, most likely because of we see more premature babies. So the risk factors are prematurity, low birth weight, multiple gestations, female sex, white race, progesterone therapy, family history, and there are other things like maternal smoking, older maternal age, in vitro fertilization, amniocentesis, CVS, chorionic villus sampling, maternal bleeding during the first trimester, placenta previa, and preeclampsia. The pathogenesis remains unknown at this point. It is speculative. The number one being stem cells with potential for proliferation and differentiation into the different cell lineages. That has been detected in patients with IH, infant hemangioma proliferation in involution. The second interesting speculation is renin-angiotensin system and hypoxia, both considered important independent pathogenic factors in the development of hemangioma. It's based on the following information, which is very interesting. The serum renin levels are 5 times that of adults during the first 3 months of life. It progressively decreases to 3 times between 3 to 12 months of age. And 2 times, the adult levels 2 times reached between 1 to 4 years of age and reaches adult levels by 8 years of age. So what is the natural history of hemangioma? It has 3 phases. 1, early proliferative phase. 2nd, late proliferative phase. 3rd, involution phase. The early proliferative phase, characterized by fast growth, takes place during the first 3 to 5 months. Rapid velocity occurring between weeks 5 and 8. That is like somewhere between 1.5 months to 2 months. By the end of this phase, hemangioma has reached an average of 80% of its final size. Late proliferative phase is slower growth, usually completed by 9 to 12 months of age, but growth can be extended beyond 36 months. The protracted growth is common when there is a large segmental or deeper hemangioma and those located in the head, neck region, particularly nasal tip, periocular, perioral, and parotid region. The involution phase starts around 12 months of age and usually lasts for 3 to 9 years. The most important thing in hemangioma is it leaves a residual change in about 70% of the patients. Deep hemangioma may have slightly later onset and has more prolonged duration of growth. There's another entity which is very interesting called hemangioma MAD, minimal or absent growth. 75% of these lesions are present at birth. The proliferative phase occurs only in part of the lesion, most of the time in the periphery part of the lesion. The involution takes similar to other hemangiomas. The clinical based upon the depth of the lesion, it can be superficial, mixed, or deep, or pattern of involvement, whether it is focal, multifocal, segmental, or indeterminate. The first picture shows superficial hemangioma, red exophytic plaque. The second one shows deep hemangioma with blue subcutaneous mass with minimal surface change. It is mixed, both superficial and deep, one can see. The fourth one is hemangioma with minimal arrested. This particular slide shows multiple focal hemangioma, often associated with infantile hepatic hemangioma, as you can see here in the sonogram of the liver. So extracutaneous involvement. Presence of 5 or more hemangiomas may signal the presence of infantile hepatic hemangiomas. Segmental hemangiomas on the face or lumbosacral area may be a feature of face or lumbar syndrome. Infantile hepatic hemangioma. Extracutaneous locations are not uncommon in patients with hemangioma, the liver being the most common. But it can happen in GI, brain, mediastinum, and lungs. The hepatic hemangioma can be focal, multifocal, or diffuse. Diffuse and multifocal hemangiomas are at high risk for complications. As we discussed earlier, the most cases are asymptomatic. The life-threatening complications in minority of the cases that could be bleeding, hypothyroidism, abdominal compartment syndrome, and congestive heart failure. Diffuse or large multifocal hemangiomas are at risk for complications. PACE syndrome. It stands for posterior fossa malformation, hemangioma, arterial anomalies, cardiac defects such as aortic coarctation, and eye anomalies. The cause is unknown. Oftentimes, it's associated with maternal history of miscarriage, preeclampsia, and placenta previa. This picture shows the picture of a child with PACE syndrome. You will see the segmental hemangioma affecting the parietal scalp and sternal pit. The MRI showing ectasia of the right common carotid and hypoplasia of the left vertebral artery. Here, the CT scan showing retroesophageal right descending aorta, ascending aorta, and the compressed esophagus and aberrant left subclavian artery. These are the clinical features of the face. As you can see, there are a whole number of things can happen in different areas like arterial abnormalities, brain abnormality, especially in the posterior fossa, cerebrovascular, ocular, and midline defects. The diagnostic criteria for PACE, the definitive PACE and possible PACE. Definite PACE, you got to have hemangioma more than 5 centimeter in diameter of the head, including scalp, plus one major criteria and two minor criteria. Or hemangioma of the neck, upper trunk, or trunk and proximal upper extremities plus two major criteria. Possible PACE, hemangioma more than 1 millimeter in diameter of the head, including scalp, plus one minor criteria. Hemangioma of the neck or trunk and proximal upper extremity plus one major and two minor. Or it could be no hemangioma plus two major criteria. These are all the major criteria and the minor criteria. It's published by 2021 American Academy of Dermatology, so it's available in their page. So what are the risk factors? I want to go one by one. So when there is an increased number of hemangiomas, more than 5, often associated with hepatic hemangiomas. So liver ultrasound needs to be done. And also look for hypothyroidism by testing TSH, T4, and T3. When the hemangioma affects bird area, airway obstruction needs to be looked into by referring the patient to ENT. Oftentimes, they can have subglottic hemangiomas. When the hemangioma is periaquelar associated with lots of abnormalities, needs to be referred to ophthalmologist. When there is a perioral hemangioma, often associated with delay in tooth eruption, enamel hypoplasia, needs referral to the dentist. This is a picture of hemangioma involving bird region. It is associated with subglottic hemangioma that could be life-endangering. When there is a large facial hemangioma, look for midline fusion defects. So complete physical examination is necessary. And look for cerebrovascular and brain structural abnormalities. MRI and MRA needs to be done. Cardiac anomalies often associated with like aortic coarctations, so echocardiography and also cardiac MRA and MRA needs to be done. For ocular anomalies, referral to the ophthalmologist needs to be done. In addition to airway obstruction, and they can have sensory neural and conductive hearing loss, again, referral to the ENT is important. When there is a midline defects, one should look for hypothyroidism. And when there is a perioral dental abnormalities, referral to the dentist by 1 year of age. The lumbar syndrome stands for lower body hemangioma and other cutaneous defects, urogenital abnormalities, ulceration, myelopathy, bony deformity, anorectal malformations, arterial anomalies, renal anomalies. Large, usually segmental hemangioma in the lumbosacral area or in the perineum, often extending towards one lower limb, is a criteria for hemangioma in the lower body. This particular picture shows segmental hemangioma with ulceration and sacral pit, sacral dimple. The MRI of this patient shows tethered spinal cord with lipomeningocele. The sonogram of this patient shows the absence of the right kidney. When there is a large lumbosacral hemangioma, meaning more than 2 to 5 centimeter, and lower leg is extensively involved, one should look for spinal cord anomalies using spinal MRI, or one can use sonogram if the patient is less than 6 months of age. Abdominal and pelvic sonogram to rule out renal, urinary, and genital abnormalities. MRI and MRV to rule out vascular anomalies. So what are the indications for the treatment? When there is ulceration or locations likely to ulcerate, example, neck, perineum, and other flexures, or anatomic location likely to cause functional impairment like periorbital, nasal, bird distribution, perioral in the ear, or infantile hepatic hemangioma, or the patient is syndromic like PACES, lumbar, or when it can cause disfigurement like face, breast in females, genitalia, etc. How to treat? Propranolol 1 milligram per kilogram twice daily is the most widely employed treatment for hemangioma requiring systemic treatment. Most infants may be safely initiated on propranolol as outpatients. Other systemic treatments reported for hemangioma include corticosteroids and others. How does it act? It will cause vasoconstriction, inhibition of angiogenesis, induction of apoptosis, inhibition of nitric oxide production, and diminution of renin-angiotensin axis. The contraindication to propranolol are second and third degree heart block, hypersensitivity to propranolol, patient with hypoglycemic episodes, wheeze, blood pressure or heart rate outside the normal range. In patients with PACE, because of the risk of stroke, always get echo and EKG prior to starting propranolol. Propranolol needs to be started at lower doses similar to preterm in patients with PACE. The starting dose of propranolol is 1 milligram per kg per day and increased one day or 1 week to an optimal dose of 2 milligram per kg per day. If the hemangioma is not responding, dose can be increased to 3 milligram per kg per day. Doses are divided into two to be taken 8 to 12 hours apart. The follow-up is required every 2 to 3 months. The dose needs to be adjusted according to the weight. In premature infants, start with 0.5 milligram per kg per day 3 times daily. Monitor heart rate, blood pressure, and glucose. Preferably admitted and gradually increase the dose till you get the stabilized dose. Once it is stabilized, they can be safely discharged. The propranolol is usually stopped at 12 to 18 months of age. Rebound growth after cessation is relatively common. The estimated frequency is 19 to 25%. The predictive factors for the recurrence is discontinuation of therapy before 9 months of age, female sex, location on the head neck region, segmental pattern, deep involvement. Propranolol is resistant to hemangioma in less than 1% of the patients. So these patients can have recurrence again. The corticosteroids is second most commonly used drug. It is used if there are contraindications or inadequate response to propranolol. The dose is 2 to 3 milligram per kilogram per day. Often needs a long course. It can be given as monotherapy or adjuvant to propranolol. The combination therapy may expedite involution of hemangioma. Other drugs used are sirolimus or rapamycin, adjunct or therapeutic alternative to propranolol. Captopril is inferior to propranolol. Vincristine is not recommended. Other modalities like laser therapy have been used. Multimodal treatment combining laser with systemic beta blockade has demonstrated superiority over monotherapy. Intralesional triamcinolone can be done, or intralesional betamethasone as an adjunctive or in non-responders. Intralesional bleomycin can be helpful, cryotherapy, surgery, especially when they have life or functional threatening hemangiomas. Embolization have been used in selected patients. The management of cutaneous complications. The complications could be ulceration, fibrofatty tissue, scarring, telangiectasia, and structural deformity. Then there is an ulceration, analgesia, bland emollients such as petrolatum, and non-aggressive dressings. The antibiotics is used only in infected patients. When you have a fibrofatty tissue and scarring, surgery, liposuction, and intralesional diabolic acid can be used. When there is a scarring like this, can be treated with ablative fractionated laser. When you have a telangiectasia after the involution, can be treated with vascular laser. If the patient has a structural deformity, they may need reconstructive surgery. This concludes the seminar on pediatric dermatologic emergencies part 2. Next week at 6 p.m. we will meet again on dermatologic emergencies part 3. If you like it, please share it with others and please subscribe to our YouTube as well as the WhatsApp channel. Thank you again.